So in the next 20 or so minutes, I'm going to talk on secondary prevention of coronary artery disease in Cyprus, having in mind that coronary artery disease is a major cause of morbidity and mortality in this country, as well as in other European countries. So the data given by the World Health Organization 2004 regarding mortality in Cyprus, coronary artery disease and stroke, so cardiovascular mortality, constitute the 1/3 of all deaths. And from this data, it's obvious how important are secondary measures for the disease. Coronary artery disease starts early in life with atherosclerosis. The formation of foam cells, biochemical level, formation of fatty streaks, small lesions, atheroma, plaques, and then complications which lead to acute coronary syndromes or to acute myocardial infarction. So atherosclerosis starts very early in life, even in children, and develops progressively over years under the influence of favorable risk factors. And the worst complications of atherosclerosis are acute coronary syndromes, which are a result of rupture or erosion of the atheromatous plaque with platelet aggregation, clot formation. The partial occlusion of the coronary artery results in non-ST elevation myocardial infarction, and the complete occlusion of the coronary artery leads to ST elevation myocardial infarction. And this is a mechanism, the pathophysiology of manifestation of coronary artery disease. We see here the subtotal obstruction, rupture of the plaque, clot formation, subtotal obstruction, which leads to non-ST elevation myocardial infarction, and here rupture of plaque, clot formation, and complete obstruction of the artery with resultant ST elevation myocardial infarction. Now, treatment of coronary artery disease is not easy. Starting early in life, before manifestation of the disease, correction of the risk factors such as smoking, obesity, hypertension, diabetes, and dyslipidemia are very substantial in controlling, delaying the manifestation of the disease, the clinical manifestation of the disease. Once coronary artery disease manifests, in spite of the primary prevention measures, then we give cardioprotective medications on secondary prevention in an attempt to reduce a new event and to prevent death. And the medicines, the cardioprotective medicines given are antiplatelets, statins, beta blockers, ACE inhibitors. Coronary artery disease is also treated, apart from these cardioprotective medications, with percutaneous coronary intervention, which is a mechanical opening of the obstructed artery with stent placement, by surgery with placement of grafts which bypass the obstructed arteries, and most important, cardiac rehabilitation, which is a lifelong program which improves quality of life and reduces new events and death. And I will stay a little bit on rehabilitation because secondary prevention measures are nothing else than cardiac rehabilitation. In 1995 and 1996, we studied 800 children in Cyprus doing primary prevention, and we found very interesting findings. We found that 59% of these children, 2 to 12 years old, had elevated plasma cholesterol. 37% of them had abnormally elevated body mass index, and 22% of them had abnormally elevated systolic blood pressure. Children 2 to 12 years old visiting Nicosia and Limassol General Hospital for other purposes. The results were published in 1999, and soon after that, a program for primary prevention in schools started by the Ministry of Health. The findings of the program were similar to our findings, but in addition, they suggested measures to control, to improve the lifestyle of the children. Now, the percentage of patients admitted in cardiology department of Paphos Hospital between 2002 and 2017, over 15 years, with a diagnosis of unstable angina, of acute coronary syndromes, acute myocardial infarction, or non-ST elevation, MI, is shown on this slide. You see that over the years, the percentage increases. So we assume from this that the prevalence of acute coronary syndromes in Cyprus is not yet controlled. But the mortality of this same group during these years declines, especially the last few years. The mortality is approximately 6%, quite low, and why the mortality is much improved during the last years? Because of the cardioprotective medications, which are very much improved, and because of primary PCI offered to these patients recently on the last years. Now, going back to 1948, the Framingham Heart Study was the first well-designed primary prevention or observational study to correlate the unknown at that time risks to coronary artery disease. And what do we know from the Framingham Heart Study? That cigarette smoking increases the risk of heart disease. And we got this information in 1960. That cholesterol levels, that blood pressure levels, and ECG abnormalities increase the risk of heart disease, 1961. Physical activity reduces the risk of heart disease, 1977. That high blood pressure increases the risk for stroke, 1970. So much of the information regarding the known today, the classical risk factors, came from the Framingham Heart Study, which started soon after the war in 1948. And this slide shows the linear relationship between total cholesterol and coronary mortality. And this one shows the correlation between the atherogenic LDL, the cardioprotective HDL. So the lowest the HDL and the highest the LDL, the higher the risk of coronary artery disease. And this one shows that when more risks are involved, for example, smoking, diabetes, low HDL, high total cholesterol, and high blood pressure, the risk increases by 6 or 7-fold compared to the group without any risks. And all this information, valuable information, came from the Framingham heart study. Now, angina, the classical presentation of patients with coronary artery disease in the hospital is always angina equivalent to acute myocardial infarction. Not always. When angina is caused by acute myocardial infarction, we have characteristic electrocardiographic changes such as ST elevation on different leads on DCG, different leads defining one specific territory of the myocardium, like this one. We have biochemical evidence of myocardial infarction, such as abnormally elevated troponins, abnormally elevated CKMB, and other biochemical markers. And once myocardial infarction manifests with a complete obstruction of the artery, damage, irreversible damage of the cardiac muscle, the myocardium, starts taking place. And this, if not treated with revascularization, will eventually lead to remodeling of the myocardium, very much impaired systolic function of the left ventricle of the heart, and higher, something that carries a very high risk for death and for impaired quality of life of those staying alive. Now, the newer guidelines of the European Society of Cardiology work out the target timing for primary PCI or for fibrinolysis. So whenever a patient with chest pain is diagnosed in the emergency department of the hospital of having an ST elevation myocardial infarction, then if there is a possibility to be transferred to a PCI facility, to a PCI hospital within 120 minutes, then this is the preferred way of therapy, the preferred therapy of revascularization. If there is no possibility of transferring the patient to a PCI hospital within this time, then we treat the patient with fibrinolysis, and then we transfer the patient to the PCI facility for rescue PCI. So this is the management strategy that we follow today in acute myocardial infarction. And we see on this slide the obstructed coronary artery. On the perfusion imaging on nuclear scans, we see that there's no perfusion on the respective myocardial wall. And once the artery is revascularized with primary PCI and stenting, perfusion recovers completely. Now, apart from ST elevation myocardial infarction, we may have a non-ST elevation acute coronary syndrome, which has a different electrocardiographic appearance. On angiography, we will observe a subtotal obstruction of the respective coronary artery as a result of a ruptured atheromatous plaque, and after deployment of the stent, the artery and revascularization and flow are completely restored. Now, this is the hospital mortality, the in-hospital mortality of patients with ST elevation myocardial infarction admitted in Nicosia General Hospital over 10 years from 2005 up to 2015. And what we observe is that after 2012, 2013, 14, and 15, mortality is very much reduced, below 6% and even below 5% in 2015 as a result of primary PCI, which was the treatment of choice on this year. If I remember well, primary PCI was introduced in Nicosia Hospital in 2012 or 13. 12. Yes. And this led to a reduction in mortality of acute MI patients. And similar trend we see in Paphos General Hospital. In hospital mortality over 15 years, starting from 2002 up to 2017. On the last 2 years, mortality is approximately is between 4 to 5% as a result of transferring the patients from Paphos Hospital to Limassol Hospital for primary PCI. And talking about primary PCI, let me tell you, let me demonstrate the distances and the time to transfer a patient from a non-PCI hospital to a PCI hospital in Cyprus. There's no national policy in Cyprus for primary PCI yet. But primary PCI is offered in Nicosia district since 2012 and in Limassol district since 2014. Patients with acute MI admitted to Larnaca Hospital, to Famagusta Hospital and to Paphos Hospital were treated with thrombolysis instead of primary PCI because these district hospitals had no PCI facilities. But in 2016, we started transferring the patients from Paphos to Limassol. It's 40 minutes away, the one hospital from the other, so it's within the 120 minutes according to the most recent guidelines. So we transfer all patients presenting to the emergency of the general hospital with symptoms suggesting acute myocardial infarction and having ECG and biochemical evidence of acute MI. We transfer all patients immediately to Limassol Hospital. The cath lab there has a service for 24 hours, so the patients receive a stent within the time period of 2 hours. And that's why the mortality is much reduced during the last 2 years. This policy of primary PCI has not yet been applied to the other hospitals, so we cannot say there is a national policy at the moment in Cyprus, but due to the small distances, I think that patients would benefit optimally from introduction of such a national policy in Cyprus. So going back to prevention, this is a design of the EuroAspire trials. The first one started in 1995-96, and the last one, the EuroAspire 4, in 2013 to 2015. So the EuroAspire trials studied the risks of coronary artery disease patients across Europe and the cardioprotective medications given. And their results, their findings, were extremely important and impressive. We can see that smoking, approximately 20% of cardiac patients continue smoking according to the EuroAspire trials after their first event. And that obesity is a major problem, from 20% up to 35% on the last trial we see that obesity, the prevalence of obesity increases in the coronary European populations. Abnormally elevated blood pressure was met in approximately 60% of patients, so this is also a major problem. And abnormally elevated total cholesterol, which was very high in EuroAspire 1, declined over time in EuroAspire 2 and in EuroAspire 3, which seems that with the introduction of new medicines, of statins, cholesterol is better controlled today than in the past. Similarly, the behavior of LDL over time improves. But diabetes, which correlates with obesity, shows an increased prevalence over time. So these are the findings of the first 3 EuroAspire trials in the European populations. Cyprus participated in EuroAspire 3 and in EuroAspire 4, not in the first 2. And these are the results on the prevalence of smoking and obesity in EuroAspire 2, 3, and 4. So obesity, the prevalence of obesity is still higher in the last EuroAspire, the most recent EuroAspire 4. And this is a prevalence of obesity in all countries participating in EuroAspire 4. In Cyprus, the prevalence is 42%. And the prevalence of well-controlled LDL cholesterol, the mean one is 21%, and in Cyprus is just the same, 21%. So this shows that we manage properly LDL cholesterol in only 21% of our coronary population. The results are not very encouraging. And these are the cardioprotective medications given in the EuroAspire 4, antiplatelets, especially aspirin, beta blockers, ACE inhibitors or ARBs, and statins, lipid-lowering statins. Now, the conclusions of EuroAspire 4 were not very good. No change in the prevalence of smoking, the prevalence of obesity, with more than 80% of high cardiovascular disease risk patients being overweight or obese. So obesity is perhaps the major problem in the European coronary populations. And the important message given by the EuroAspire 4 was that there is an urgent need of healthcare systems to invest in prevention, in secondary prevention. Well, is always smoking and other risks harmful? Patients see an optimistic message from all this. For example, they get out to smoke because they are out in the fresh air, for example. They have many excuses. Now, coming back to our country, these are the surveys designed in Cyprus starting from 2002 up to 2017. We studied 1,200 patients, over 500, over 600, and over 350 patients in the last survey in different time periods, just to see whether there is an improvement, what is the tendency in our population, our coronary population. Are our findings parallel to the European findings, to the EuroAspire findings? Are we in a better position than the Europeans or in a worse position than the rest of Europe? And the majority, of course, of the coronary population, as expected, are males. going back to 2002 up to 2005, this is a prevalence of smoking, 23%, of obesity, body mass index above 30, of elevated cholesterol, of elevated blood pressure, and of diabetes. So, at the beginning of 2000, the management we are offering to our patients, as you see, was not very good. The patients who are visiting the hospitals, the cardiology clinics, the cardiac clinics, we are giving them a handful of pills, but these are the results. If you don't do a quality survey, you don't study the results of your treatment, you never know. You think you are perfect in treating a patient, in treating your society, treating group of patients, but these are the results. They are not very good. And look, the percentage of the cardioprotective medications given, 94% were given aspirin, 60% beta blockade inhibitor, almost 90% were taking a statin. But the control of cholesterol was not good, in spite of the fact that 90% of them were taking a lipid, an effective lipid-lowering medicine. Supposedly, yes. We moved to, a few years later, to a new survey. And what we found, that we have more smokers, more hypertensives, and more diabetics. But we managed to control somehow the levels of cholesterol and of obesity, somewhat lower obesity in the population. And the cardioprotective medicines, more than 90%. Statins, antiplatelets, beta blockade inhibitors. In 2002 and 2012 and 13, we studied 650 patients in Nicosia area. And the results were quite good. Less smokers, less obesity, better control of cholesterol, better management of blood pressure, and less diabetes, better control of diabetes during their visit to the cardiology clinics. And the medications given, almost 100%. The last survey, during the last 2 years, quite good number of patients, 350 coronary artery disease patients having myocardial infarction, PCI or bypass surgery, smokers, obesity, and diabetes. So smoking, obesity, and diabetes are the main problems in our coronary artery disease population. We managed to control properly, or better than previous years, lipids and the blood pressure. But diabetes, obesity, and smoking, the lifestyle measures are poor. And you see that almost all our patients who are receiving cardioprotective medications. And these are the results of the 4 surveys together and the cardioprotective medications. And what are the conclusions from our surveys? That we observed an improvement in cardioprotective medications over time. We have better medicines. We understand their mechanism better than before. We feel very confident in giving them because we have obtained experience so many years in giving specific medicines. So an improvement in cardioprotective medications has been observed. There is a better control of cholesterol and of blood pressure. But the lifestyle-related smoking, obesity, and diabetes are still a major problem. And so we understand that there is a need for introduction of cardiac rehabilitation programs in Cyprus. And cardiac rehabilitation programs are important. And the most recent European guidelines on the management of coronary of myocardial infarction patients give the highest evidence, the highest indication and evidence to cardiac rehabilitation programs, 1A. And this is the group involved in cardiac rehabilitation: physician, therapist, nurse, occupational therapist, psychologist, nutritionist, exercise physiologist, so whole group. If we go back to EuroAspire 3, which studied also the prevalence of cardiac rehabilitation across Europe, we can see that advice to follow a cardiac rehab program in Cyprus was given to only 5% of patients having MI, PCI, or bypass. Only to 5%. And only 0.5% of them attended the cardiac rehabilitation program. EuroAspire 3, quite recently. So, to do or not to do exercise, to do or not to do rehabilitation. Smoking cessation, increasing physical activity, healthy eating, and better weight management are the target of cardiac rehabilitation programs. But before moving to cardiac rehabilitation in Cyprus, let me tell you something on depression. I haven't mentioned depression till now, but depression seems to be a major problem in cardiology. And why is that? The prevalence of depression in chronic disease is shown on this study from 1998, Mayo Clinic procedures. And we see that 25% of MI patients, 23% of stroke patients, and 17% of stable angina patients had depression. And why depression is important? Depression is important because it is associated with an increased mortality. And the time of appearance of depression in coronary artery disease may be in 1 year, in 2-3 years, 3 to 5 years, and even after 5 years, in a nice study published last year in the European Heart Study. So, having this in mind, that depression is also a new, let's say, risk factor in coronary artery disease, which increases the adverse effects of the disease. In 2010, we studied a small group in our hospital in Paphos. And the results were published later in the Oxford Handbook of Dance and Well-being, edited in 2017. All 12 patients had acute myocardial infarction and were admitted in our cardiology department. The data collected for the purpose of this study was done by observation, by interviewing the patient from the clinical notes, by filling questionnaires and inventory scales. And the statistical analysis was done for quality of life questionnaire and from Beck's depression inventory scale. A written approval was obtained from all patients, from the hospital, a consent form signed by each participant. Beck's depression inventory and quality of life questionnaire were completed for each on the day of enrollment and 1 month later. Interviews took place before and after dance movement psychotherapy sessions. DMP is included today in cardiac rehabilitation. 4 DMP sessions were provided individually to each patient. The sessions included discussions, relaxation and breathing techniques, and minor movements. And the results were very impressive. This is the change observed in quality of life of the patients. So before and after DMP sessions, there is an improvement in the quality of life in all parameters studied. And as far as depression is concerned, which, as we saw before, is a major risk factor and an adverse risk factor for mortality in coronary patients, we also see that based on the Beck's inventory scale, we see that there is an improvement, a shift to the left of depression of our patients following DMP sessions. So severe depression was not observed anymore after 4 sessions of DMP. Moderate depression was reduced, mild depression was reduced, and non-depressed patients were more than before. In the long-term management of coronary artery disease, psychosocial health is very important, medical risk factor management, cardioprotective medications, and lifestyle risk factors. And all these 3 belong to the cardiac rehabilitation programs, which have not yet been developed in our country. Last year, we started slowly in Paphos Hospital, a small district hospital in Cyprus, to provide cardiac rehabilitation in our patients. We recruited in 2017 30 patients presenting with acute myocardial infarction and having primary PCI in Limassol and then back to Paphos for recovery. So all 30 were recruited. 2 of them had bypass surgery. Stage 1 sessions, rehabilitation sessions with a physician and a physiotherapist were applied in the hospital during the 3 or 4 days of their stay, and plans to start stage 2, group discussions and screening of quality of life and the risks, have been done but not applied yet. The patients were not called back. The group increases because we recruit more patients every week. So the target is that every patient presenting to Paphos Hospital with acute MI and having a primary PCI in Limassol Hospital, then back for recovery, to be offered stage 1 rehabilitation in the hospital, and then to be called back in a group session for stage 2 rehabilitation. This is a very initial stage, and I have no results to show regarding the parameters shown before. And we are on the way of seeking support from the Ministry of Health, from the Cardiac Society, in applying the program. So let me remind you, and this is the last slide, let me remind you the cardiovascular risk factors before finishing, modifiable smoking, obesity, physical inactivity, hypertension, diabetes, and dyslipidemia. Non-modifiable, what nature gave us, and emerging risk factors, C-reactive protein, fibrinogen, homocysteine, calcification of the coronary arteries, small dense LDL, and finally, depression. Thank you very much for being here.